Today we will have two sessions on hemophilia. One is an introduction to the basics of hemophilia, and second session will be focused on the management of specific bleeding manifestations in hemophilia. So, with that introduction, we will go into the first session, that is basics of hemophilia. So, this is a picture showing the primary and secondary hemostatic mechanisms. So, as you all know, for a blood clot to form, there are two pathways for hemostasis. One is the primary hemostasis, which involves the platelet, subendothelial collagen, and von Willebrand's factor, which results in the platelet plug formation. This will be followed by formation of some amount of thrombin, and this is followed by the secondary hemostatic mechanism, which involves all the coagulation factors. So whenever the subendothelial collagen is exposed, the tissue factor is also exposed, and this tissue factor, when it comes into contact with factor 7 in circulation, factor 7 is activated, and via the extrinsic pathway, you will get thrombin formation. And this thrombin, which is already formed, is a potent initiator of initiator and activator of all other coagulation factors, so that the subsequent major thrombin formation occurs through the intrinsic pathway, and the final fibrin clot is formed. So that is the primary and secondary hemostasis. So in this coagulation cascade, as you know, there is one on the right hand side is the exposed tissue factor along with the factor 7, that is the extrinsic teenase complex. And next is the intrinsic teenase complex. So in the intrinsic teenase complex, you can see there is the factor 9, factor 8, phospholipid, and calcium. So this is the intrinsic teenase complex, and these two complexes can activate the final prothrombinase complex, which consists of factor 10, factor 5, phospholipid, and calcium, which in turn converts fibrinogen to fibrin. Then the cross-linking of fibrin and the final fibrin clot is formed. So that is the coagulation cascade. So we are here concerned mainly about the factors of intrinsic teenase complex, that is factor 8 and factor 9. In this, as you can see, all these coagulation factors, 13 coagulation factors are listed. So in this, we are interested in factor 8 and factor 9. As you can see, both these are X-linked recessive inheritance. And you can see that the incidence of factor 8 is 1 in 5,000. That is, statistically, factor 8 deficiency or hemophilia A is the most common coagulation disorder. Next is factor 9. The incidence is about 1 in 30,000 population. When you compare this with the incidence of all other coagulation factor deficiencies, you can see that all other coagulation factor deficiencies are inherited as autosomal recessive traits, and their incidence is very low. That is 1 in 1 million, 1 in 2 million. So that is the difference between hemophilia A and B and the other coagulation disorders. That is, statistically, more common is hemophilia A and hemophilia B. Coming to the genetics of hemophilia. So we should know a little bit about the genetics of hemophilia. And hemophilia A is most commonly caused by the inversion of intron 22, which is the most common mutation seen in hemophilia A. And this is present in 40% cases of severe hemophilia. So there are many other mutations. Some 500 different mutations are identified in the hemophilia A gene and hemophilia B gene. But since this is the most common mutation identified, many a time when we diagnose an index case in the family, we will ask for inversion of intron 22 mutation to be studied first. And if that is negative, then it will be proceed with further other mutations. So hemophilia, this is an X-linked recessive disorder. Since it is X-linked recessive, it mainly affects males on the maternal side, and females are usually carriers. And both factor 8 gene and factor 9 gene are prone to new mutations. So in 2/3 of the family of cases of hemophilia, you will get a family history. But 1/3 of all these cases results from spontaneous mutation in the germline. So in those cases, you will not get a family history. And these cases are labeled as sporadic hemophilia. So whenever we get a case of hemophilia, we should attempt to draw a family tree and pedigree chart and trace all the cases. So in these cases, 80% mothers are carriers of de novo mutated allele. So in the inheritance of hemophilia, 3 scenarios can occur. In the first scenario, the father is a deceased person, the mother is not a carrier. In such cases, none of the sons will have the disease because there is no transmission from father to son in case of X-linked recessive inheritance, but all the daughters will be carriers of the disease. In the second scenario, this is the most common. That is, the father is not affected, but the mother is a carrier of hemophilia gene. In this case, among the offspring, 50% of the male children will be affected by the hemophilia, and 50% of daughters will be carriers. So this is the most common scenario that we encounter. And in the third situation, the father is a deceased person and the mother is a carrier. This is very, very rare. In such cases, 50% of the male children will be affected. There is a chance of female hemophilia, female daughters having the disease in this situation, and 50% of the daughters will be carriers. So there are only very rare situations where you will get a female with hemophilia. So this is one such situation. That is a male with hemophilic affected person marrying a carrier female. So that's one rare situation where you get a female hemophilia. So the incidence, as we already told, is 1 in 5,000 in case of hemophilia A and 1 in 25,000 in case of hemophilia B. So 80 to 85% cases will be hemophilia A, while the rest, that is 10 to 15% cases will be hemophilia B. And when to suspect hemophilia? Whenever a patient presents with easy bruising, spontaneous bleeding, that is bleeding without any apparent cause or reason, particularly into the joints and muscles and other soft tissues, you should suspect hemophilia. Or in any case, if there is an excessive bleeding following a trauma or surgery, which is excessive, both excessive and prolonged, you should again suspect hemophilia. And whenever children develop joint bleeds and muscle bleeds at very young age, like 6 months to 1 year, in such case also, hemophilia should be suspected. So that is the introduction and basics regarding hemophilia. Now coming to the classification of severity of the disease. Since these clotting factor proteins are present in our plasma in very minute quantities, in terms of nanograms, for our ease of quantification, this factor levels are usually expressed in percentage and international units per deciliter. So that is the arbitrary values. It is expressed in percentage and international units per deciliter. So depending upon the factor levels, WFH has defined hemophilia as any person with a factor level less than 40%. And the normal population average of hemophilia will be 50 to 150%. Because when you take 100 people, their factor levels will lie somewhere between 50 to 150%. And if it is less than 40%, you can call it as hemophilia. And this is again divided into mild, moderate, and severe hemophilia. Severe hemophilia is factor level less than 1%. Moderate hemophilia is factor level between 1 to 5%. And mild hemophilia is factor levels between 5 to 40%. What are the bleeding manifestations in each of these categories? So as you know, less than 1% of normal, that is severe hemophilia, is the most severe manifestation of the disease. Here the disease is characterized by spontaneous bleeds into muscles and joints. And predominantly in the absence of any identifiable challenge. And apart from this, they can develop prolonged and excessive bleed after any minor or major hemostatic challenge like trauma or surgery. Coming to moderate hemophilia, these patients' spontaneous bleeding will not occur. Usually it will not occur, or it is very, very, very rare. But they can develop prolonged bleeding with minor trauma or minor surgeries also. And very occasionally they can develop spontaneous bleeding. Now coming to mild hemophilia, you will not get spontaneous bleeds, but these patients bleed after a significant trauma or surgery. And whatever patients we see in our routine clinical practice who are under treatment are usually mostly severe hemophiliacs. And rarely only you will get moderate hemophiliacs and mild hemophiliacs. Usually the bleeding manifestations in hemophilia is lifelong. And children develop symptoms when they start crawling, walking, or running. That is around 8 months to 1 year, they can develop symptoms. So, following falls, they will develop a joint bleed and joint pain, and the child will start crying due to the joint pain or a muscle hematoma. Very rarely, even in the first year of life, they can develop events like severe bleeds like intracranial hemorrhage. Sometimes hemophilia will be first diagnosed following bleeding following circumcision. And patients with mild hemophilia will not be diagnosed sometimes till adulthood. When they are first exposed to surgery, sometimes it will be diagnosed only at that level. Now, what are the sites of bleeding in hemophilia? Again, the bleeding manifestations are divided into life-threatening bleeds and serious bleeds. In the life-threatening category, you get 3 bleeds, that is intracranial bleed, neck or hemorrhage into the throat, and gastrointestinal bleed. Because the hemorrhage into the throat can cause compression into trachea and cause severe respiratory compromise, it is regarded as a life-threatening hemorrhage. All other bleeds are characterized as serious bleeds, amongst which the most common is joint bleed or hemarthrosis, followed by muscle hematomas and other mucous membrane bleeds. Like you can develop bleeding from any site, like oral, gingival bleeds, oral cavity bleeds, gums, nose, genitourinary tract. All these sites can involve with the bleeding. Statistically, most common is the hemarthrosis and more common in the hinge joints like knees, ankles, elbow, and other joints like hip, shoulders, etc. also can be affected by a bleed. And 70 to 80% bleeds in hemophilia are due to hemarthrosis. This is followed by muscle hematomas. In 10 to 20% cases, you will get muscle hematomas. While all other major bleeds, the incidence is 5 to 10%, and incidence of CNS bleed, intracranial bleed, is only less than 5%. So among the joint bleeds, the most common will be knee, and most of the patients who have target joints will be knee will be the target joint. So you can see in this picture the picture of a hemarthrosis. Patient will have a painful joint which is swollen, and the usual landmarks of the joint will be lost. It will be diffusely swollen. But since this is the first event, patient will not have any muscle atrophy. The muscle bulk will be normal. Apart from this, the patient will have severe limitation of movement. The patient will not move the joint because of pain. So this is the hemarthrosis, and if it is left untreated, it will initiate a vicious cycle, or what we call the bleed cycle. Because of the bleed and pain, patient will keep that limb immobilized, and this, if left for a prolonged immobilization, this will initiate a flexion reflex. And finally, the joint will develop a joint stiffness and muscle with a muscle tightness. And if it is allowed to stand for a long time, muscle will finally develop atrophy. And this atrophied muscles, the muscle strength will be less. And as a part of that, the joint will become more unstable, and they are prone for recurrent falls due to this event. So that is the bleed cycle. So that gives the importance of why we should treat each hemarthrosis on time. So the acute bleeding manifestations and their treatment will be dealt with in the next session. So we'll directly go into the chronic complications of hemophilia. This is also an important, because many of time when a patient comes to casualty, they will be having a swollen joint, and we will be in. We have to identify whether this joint is due to a chronic complication, or if patient has an acute hemarthrosis on the top of that. So what are the chronic complications that also we should be aware of? So chronic complications of hemophilia are of 2 types. One is the musculoskeletal complications, and the other is the treatment related complications. So the musculoskeletal complications are, first one, the chronic synovitis. Second, the chronic hemophilic arthropathy or the deforming arthropathy, contracture, pseudotumor, and fracture. So these are the musculoskeletal complications of hemophilia. And the treatment related complications are, one, inhibitor formation, and the transfusion related or clotting factor related complications like viral transmission risk. After enlisting the chronic complications, we'll go to the lab diagnosis of hemophilia. Before going to the lab test, we should know there are certain precautions that we should take when we draw a sampling. Ideally, blood sampling for these coagulation tests should be taken in fasting state. And we should avoid medications that can affect the results like aspirin, NSAIDs, etc. should be avoided. And the most important fact is that all these tests should be ideally done within 1 hour of sample collection if it is kept at room temperature, that is 18 to 25 degrees. If you expect a delay more than 1 hour, this sample should be stored or transported in ice. And ideal needle size for sample collection is 19 to 21 gauge needle. And whenever you draw these samples, try to avoid frothing, and application of a firm tourniquet is also not advisable while drawing the sample. And the sample for coagulation studies is the citrate sample, that is the blood citrate ratio of 9:1. And this blood sample is usually centrifuged and the plasma is stored. And if the if we expect a delay of more than 1 hour, this should be transported or stored in ice. And all these samples which are stored should be tested within 8 hours of collection. And if you expect a delay more than that, it should be deep frozen at -35 degree or lower. And if the samples are stored at -70 degree or lesser, it can be kept for months, like in the tune of months, like 2 to 3 months also, these samples can be stored for testing. But in all situations, the ideal scenario is completing the test within 1 hour of sample collection. The basic screening tests for coagulation studies are: whenever a patient present with bleeding or coagulation abnormality, we have to order for 4 basic tests, that is platelet count, bleeding time, prothrombin time, and APTT. And if any one of these prolonged is abnormal, you can proceed with the algorithm for that abnormality. And in hemophilia A and B, what you expect is a prolongation of APTT, while all other tests mentioned in this will be normal. And whenever APTT is prolonged, our next important question is whether we are dealing with a factor deficiency, that is a inherited coagulation disorder like hemophilia, or whether we are dealing with inhibitors. This question can be addressed by doing what we call the mixing studies. That is, we are mixing the patient's plasma with pooled normal plasma to see whether APTT is getting corrected. So if it is a deficiency, you will get a correction of APTT. If it is an inhibitor, you will not get your APTT correction. It will still be prolonged. And based on that, we can do further tests. Next test to be done is the factor assays. This factor assay, first we will proceed with factor 8 because that is statistically most common disease, followed by factor 9 assay. So this will help to determine the diagnosis. And after making a diagnosis of factor 8 deficiency, further we will not do factor assays frequently. It is further indicated only in certain special situations, like whenever if the patient is going for surgery. If we are treating a bleeding manifestation but the patient is not responding, then we want to know the recovery of factor 8. So in such special situations, we will be doing factor assays. So in this table, you can see that in hemophilia A or B, you will get a prolonged APTT, while the PT, bleeding time, and platelet count will be normal. In case of von Willebrand's disease, again, you get a prolonged APTT, but here the bleeding time also will be usually prolonged. And you get, if a type 2B von Willebrand's disease is there, you will get a low platelet also. In the case of platelet disorder, if it is a thrombocytopenia, you will get a low platelet count. And if it is a platelet function disorder, your coagulation screening test PT APTT will be normal. So each of these labs will be having a normal range of APTT. Usually it is in the range of 25 to 35 seconds, and PT usually is in the range of 12 to 15 seconds. Whenever an APTT is 5 seconds or more prolonged from the control, you will take it as a prolonged value. 5 or more seconds of prolongation between test and control value. And in the case of PT, if there is a prolongation of 2 or more seconds between the tester and control, you will take it as a prolonged value. So in some rare situations, like in case of mild hemophilia, very rarely APTT can be within the normal range. So these screening tests, these 4 tests, may not detect abnormalities in patients with very mild bleeding disorders. Then including some forms of mild hemophilia, some variants of von Willebrand's disease, factor 13 deficiency, and disorders of fibrinolytic pathways. So these are diseases where your screening coagulation tests can be normal. So this picture shows the mixing studies. We are mixing the patient's plasma 1:1 mixed with the normal pooled plasma. And we repeat APTT after this mixture. If the APTT is getting corrected, your inference is there is a factor deficiency. If it is remaining elevated, APTT is still prolonged, that is a factor inhibitor. So factor assays, what do we do what do we mean when we say a factor assay? But routinely in our labs, we are doing the one-stage clot-based APTT-based factor assay. That is the commonly used technique for assessing the factor level. And other technique is the chromogenic or and fluorogenic clotting factor assays are available at major institutions, because in some rare situations, this clot-based APTT or clot-based factor assays can be normal. But in such cases, if we are strongly suspecting a coagulation disorder, you have to proceed with the chromogenic assay to get the correct diagnosis. And next important question. Now we have made the diagnosis of hemophilia by doing a factor assay also. So the next question is whether to proceed with the genetic testing. For most all people with severe hemophilia or moderate hemophilia or low borderline factor activity levels, WFH recommendation is to proceed with the genetic test, that is intron 22 inversion and intron 1 inversion as a genetic testing. At least in the proband or the index case, it should be genotyped. So more other family members also will be having the same mutation. This is because in a family, whenever a male child is affected, when the mother is becoming pregnant again, they will have this doubt whether the second child also will be having hemophilia. So in such cases, we have to ask them to proceed with a prenatal diagnosis by a chorionic villus sampling or amniotic fluid biopsy, chorionic villus biopsy or the amniotic fluid sampling. In such case, if the genotype of the proband is already known, that is the same genetic test can be applied to the prenatal diagnosis. So WFH recommendation is to proceed with the genetic testing whenever a child is diagnosed at the youngest age. And this has other implications also. Sometimes by knowing the genetic abnormality, we can predict their chance of developing inhibitors. We can assess predict their phenotypic severity. So hence, now the lab diagnosis of hemophilia is almost complete. So next we will deal with each of these individual complications, chronic complications of hemophilia. So we have already listed the complications previously. So we will go to each of these complications. The first is chronic synovitis. Chronic synovitis is the first complication that develops when a hemophilic acute hemarthrosis is left untreated or inadequately treated. So this develops in the first and second decades of life. After developing repeated bleeds, the patient will develop synovial hypertrophy, leading to a friable synovium. This friable synovium is prone to develop recurring bleed, and this recurrent bleed will finally damage the articular cartilage. So how will you diagnose a chronic synovitis? Patient will have a painless joint. That is the characteristic of chronic synovitis. The joint will be painless. It will be markedly swollen, but it is totally painless. And you can palpate the soft boggy synovium. There will not be any restriction of movement. Patient's range of motion will be full, and the muscle strength and muscle bulk will be normal. There will be no muscle atrophy. So that is the characteristic of chronic synovitis, and you can confirm this by doing a USG or MRI. So this is a picture showing chronic synovitis. Again, when you take an X-ray, you can see the soft tissue shadow, enlarged soft tissue shadow of the boggy soft and hypertrophic synovium. So how will you manage? Actually, this chronic synovitis is amenable to resection, either surgical resection or non-surgical resection. Now, the non-surgical methods like the radioactive SYNOVIORTHESIS is very much popular. For this, you can use yttrium. So the radioactive SYNOVIORTHESIS is now very popular. This can be done under factor coverage, and once this is done, the chance of developing recurrent bleeds is markedly reduced. Now, the next complication is chronic hemophilic arthropathy. Here, you will get all the changes in the cartilage, articular cartilage, and the subchondral wall. So here you can see that there is some amount of blood in the joint cavity. There is cartilage degeneration. There is neovascularization. There is subchondral osteophytes. There are some subchondral cysts. Then there is epiphyseal enlargement. There is significant osteoporosis. Finally, this will lead to total loss of joint space and bony ankylosis and flexion deformities. So in this X-ray, you can see that the joint space is totally obliterated. So that is chronic hemophilic arthropathy. This is a flexion deformity due to chronic hemophilic arthropathy. So again, an elbow showing total disruption of the joint anatomy due to chronic hemophilic arthropathy. So there are some detailed radiological manifestations, like you will get periarticular demineralization, marginal erosions, subchondral irregularity, decrease in the joint space, osteophytes, chondrocalcinosis. All these you can visualize in the X-ray. Once the joint is totally, you can assess the joint health score, but there are some scoring systems like HJHS, Hemophilia Joint Health Score. So this scoring system has been devised by WFH, and we can use this scoring system to, and each of these, there are several components, and based on that, patient's joint health can be assessed, and based on that, you can advise physiotherapy followed by surgical management. So the final management for this chronic hemophilic arthropathy will be knee replace. Whichever joint is affected, you can ask for a knee replacement, hip replacement, or whatsoever. And up to before going for a replacement, you can there are several other procedures which can be tried, like osteotomy, arthrodesis, then serial casting. So there are several techniques which are usually done by physiatrists for the correction of the deformities before proceeding with a replacement. Now, next most important complication is pseudotumor. This is very rare, seen in only 1% of cases. This is a complication arising after a suboptimal treatment of a hematoma. So whenever you are leaving a hematoma suboptimally treated, the hematoma can remain as such, even though the size may decrease. And this hematoma finally develops a capsule and become an encapsulated hematoma. And this encapsulated hematoma can draw its own blood supply from the nutrient arteries of the bone. And finally, it results in periosteal hemorrhage, periosteal elevation, bony erosions, and all the bony landmarks are lost. You will lose the differentiation between the bone and soft tissue. And finally, a single swelling, which involves this hematoma, the capsule, the adjacent muscles, soft tissues, bone, everything will grow into a single swelling, what we call as a pseudotumor. It can usually involve the long bones or pelvis. The pelvis pseudotumor can occur following an untreated psoas hematoma. This is usually painless. That is one thing which this pseudotumor will be growing, but patient will not experience any pain till the final stage. So we should be very careful in treating all the hematomas and ensure resolution of all the hematomas. So once this is formed, the only treatment will be complete surgical resection with factor cover and bone grafting. So our aim is to prevent the development of any pseudotumor. So this is the picture of a X-ray showing a pseudotumor. You can see that the whole bone is disrupted. Now, next important complication is fracture. Many of these patients can sustain fracture following trauma and come to our casualty. What we should take care that we should maintain at least 50% factor level, and this should be maintained for 3 to 5 days. And depending upon the hemostasis, you should maintain a lower factor level for subsequent 10 to 14 days, and surgery if needed, and proceed with physiotherapy. So this slide shows the hemophilia joint health score. This is all freely accessible in the net. We can take a printout of this, and when each patients come, we can give a joint score for these target joints, and decide whether this patient should go for an active physiotherapy with joint replacement, etc. So this helps to refer the patient for joint replacement. Now, next important complication for hemophilia is formation of inhibitors. Inhibitors are neutralizing antibodies, IgG antibodies, that can neutralize the action of the clotting factors. So this is the most severe treatment-related complications in hemophilia. So inhibitor is classified into two types. One is a low responding inhibitor or a low titer inhibitor. Whenever we do an inhibitor screen, this is followed by what is called a Bethesda assay, for which we keep the factor patient's plasma, and pooled normal plasma is incubated, and we do this factor inhibitor level at the incubated mix and fresh mix for at 0 hour, 30 minutes, 1 hour, and 2 hours. And then we assign a value for that inhibitor, which is expressed in Bethesda units. And whenever it is less than 5 Bethesda units, you call it as a low responding inhibitor. Whenever it is more than 5 Bethesda units, you call it as a high responding inhibitor. Because this factor 8 inhibitor is a late acting inhibitor. That is why we are keeping it incubated at 37 degrees for 2 hours and serially assessing the APTT to assess the inhibitor. Now, epidemiology of inhibitors. It is statistically more common with hemophilia A. Now, there is a lifetime risk for developing an inhibitor is 20 to 30% in case of hemophilia A, while it is 5% in case of hemophilia B. And whenever a patient with severe hemophilia develops inhibitors, there is a chance that they bleed more frequently, and these bleeds become more difficult to manage. And whenever a patient with moderate hemophilia develops an inhibitor, they starts behaving as severe hemophilias. So there will be a sudden change in the bleeding pattern when a patient develops inhibitor. and these bleeds will be fail to respond to our conventional factor therapy. That is the time when which we suspect inhibitors. And usually in severe hemophilia, so whoever develops inhibitors usually do so in the first few years of life. So there are several factors which decide the development of inhibitors. Most important is genetic factor, that is large gene deletions or null mutations in which a large part of hemophilia gene is deleted. Such patients are more likely to develop inhibitors. Then the peculiarities of patients' immune system, like the MHC class phenotype, the T cell repertoire, all these will decide the development of inhibitors. Next is our treatment related factors, that is what dose of factor we are using and for what duration we are using. Patients who are treated for prolonged duration, like for example for a CNS bleed or for a surgery, patients who are given very high doses, these patients are especially at risk of development of inhibitors. So routinely, if we are treating for prolonged periods or if we are treating with a higher doses, this should be automatically followed by an inhibitor screen within 4 weeks of exposure. So this is one important question which the patients ask. Many a time, all these children will be asked to go for prophylaxis. So they will have a doubt whether they are frequently exposed to factors, whether they will develop inhibitors. So this picture in the blood journal clearly states that in the first line, that is the dotted line above is the on-demand treatment, and the complete line below is the prophylactic treatment. And in the exposure, in the x-axis, you get the number of exposure days, and the y-axis, you will it is depicting the cumulative incidence of inhibitors. So you can see that the chance of developing inhibitors is more with on-demand treatment than with prophylactic treatment. So that is very clear. Again, the same thing. The chance of developing inhibitors is more with on-demand treatment than with prophylactic treatment. The most important question is whom to screen for inhibitors. So in children and in adults, there are separate indications. Children, all of the children will be usually on prophylaxis. So there are some specific time points at which we should screen for inhibitors. Until their 20th exposure day, inhibitor screen should be done for every 5 exposures. Between the until their 50th exposure day, inhibitor screen should be done every 10 exposure days. That is between the 20th exposure and 50th exposure, it should be done every 10 exposure days. And until the next 150th exposure days, that is from the 50th exposure day to the 150th exposure day, you should do inhibitor screen at least 2 times per year. So that is for children who are on prophylaxis. Now, if they are beyond 150 exposure days, or in case of adults, when should you do an inhibitor screen? All the patients should be suspected to an inhibitor screen at least every year. Next is whenever there is a failure to respond to adequate factor level, they should be subjected to inhibitor screen. Then whenever you are embarking on any surgical procedure for hemophilic patients, you should always do inhibitor screen prior to the surgery, because we should know whether patient is going to respond to our factor therapy. And whenever we are switching to in between products, then also we should proceed with an inhibitor screen. So what is the problem due to inhibitors? High responding patients with low responding inhibitor, that is less than 5 Bethesda units, sometimes over time this inhibitor can become negative, but high responding inhibitors tend to persist, and this inhibitor patients can develop an amnestic response, that is sudden increase in titer when they are further exposed to factor therapy. Now coming to the inhibitor treatment of inhibitor is usually with the bypassing agent, about which I think we will cover in the next slides. Next session. Patients with inhibitor, we will use mainly the bypassing agents for treatment. If it is a low titer inhibitor, there is one school of thought that you can use very high factor dose. But if it is a high responding inhibitor, usually we treat with bypassing agents. So there are bypassing agents. There are 2 bypassing agents which are usually available now. One is the recombinant activated factor 7A and the activated prothrombin complex concentrates, which contain prothrombin, that is factor 2, factor 9, factor 10, etc. Otherwise called the factor 8 inhibitor bypass activity, FIBA, or the factor 8 inhibitor bypass activity. Okay, I think about the product in detail we will cover in the next session. So this is regarding recombinant factor 7A and the FIBA, or the prothrombin complex concentrate. So in the first product, that is recombinant factor 7A, main content is factor 7, while in the FIBA the main content will be prothrombin, factor 9, factor 9 and factor 7. So without, even when in the presence of factor 8 or factor 8 inhibitor, these products will promote a clot formation by alternative pathways. Only problem is that recombinant factor 7a, the half-life is very short, 2 to 3 hours. So you have to use it very frequently. And for FIBA, the half-life is 8 to 12 hours. And infusion volume for factor 7 is 5 ml, while that of FIBA, it is 90 ml. So you have to dilute it in 100 ml saline. And the dose for Nova 7 will be, or activated factor 7 will be 90 to 120 microgram per kg every 2 to 3 hours, while that for FIBA will be 50 to 100 units per kg. And one black box warning is that these two products, when we use it in higher doses, they are prone to develop thrombotic complications. Again, the same factors are given in this slide. I think we will skip. These are all efficacies. Only thing which we want to convey is both these products, factor 7 or FIBA, either of these we can use in patient with inhibitors. And the less costlier option will be FIBA. Regarding efficacy, both these have similar efficacy. But some patients respond to FIBA very easily, but some patients may not. And some patients respond very well to activated factor 7. So by our experience only, we will know which patient is going to respond to which product. So other treatment options we can use is newer several drugs are available for prophylaxis for inhibitor patients, like emicizumab, which is a monoclonal antibody, and several other drugs like concizumab, fitusiran, tissue factor pathway inhibitor, monoclonal antibody. All these are in pipeline for the management of patients with newer options, and other treatments like gene therapy are now being started. Okay, I think with this we will wind up with this session on basics of hemophilia.